Hello, everybody. My name is Katarzyna Wac. I'm really happy for being able to present our work in Quality of Life Technologies Lab at the University of Geneva. Thank you, Chris, for a kind introduction. And I would like to continue in this discussion about how technology can help us to better assess and improve the quality of life of our patients, participants, individuals, and ourselves. So I will also talk about some correlations, continuing the discussion from the previous talk. I'll talk about longitudinal data sets. I will talk about different networks. I'll talk about Wi-Fi networks, 3G networks, 5G networks coming, and looking into how can we construct this early warning system. And specific approach, which I'm presenting here, and it's very much a work in progress, really this developing story, is co-calibration methods of really co-calibrating the physical, psychological outcomes in individuals with the consumer wearable activity outcomes. So let's start from a data model, which most of you have in mind, where on one hand we have a sources and different sources and different types of outcomes, which are then taking consideration in our research, but also in clinical decision making, and which are then collected as a total of evidence for interventions or other aspects of healthcare. So on the left-hand side, we have the patient-reported outcomes, which are then the subset is called self-reported outcomes. And on the right-hand side, we have clinician-reported outcomes, performance-reported outcomes, and technology-reported outcomes. And in the middle, there are observers or proxies. This particular taxonomy has been developed by Nancy, our long life ISOQOL contributor. And I would like to just point out that in my talk, I will refer to PROS as anything being patient reported and TECROS as anything which is patient generated or individual generated. Ideally outside of the lab, in situ, in the wild, as we call it. So let's go through the PROS and TECROS, and let's discuss their potential, specifically the TECROS. Here we are today talking about technologies. So we do know current status of our worldview, in a sense, where patient-reported outcomes and this wonderful world of self-reports is bringing us into sometimes very infrequent interactions, quite subjective, some aspects of bias due to memory bias or social acceptable answers, and quite qualitative evaluations can come into the discussion of how valid are this particular data which we're collecting from just asking people how they feel. And I do know the whole ISOQOL team, the whole field of quality of life is looking into ways of assuring the validity. So this is not a question. It's just, I think we can do better. So the big picture is, we do know that we do have our smartphones next to us. And actually from our previous research, already back in 2011, we had this particular number. We have been following 30 participants for a few weeks, and we've been really assessing technologically how far is their phone. So 88% of the time, the phone was at least in the same room. And for some participants, specifically male participants who have pockets, the phone was on them more than 90% of the time, and as close as 1 meter. Nowadays, we know also that there are wearables, right? The wearables and the devices on the body. So here they are. Many of you now listen to me and maybe looking at your heart rate, or have you done enough steps, or you take a stretch because it's time to get a little break. And in our previous research, being curious about these different devices, we have done this review of 438 wearables 2 years back, and we were looking at what did they actually monitor, what kind of data sources are there, which could be then prominent into leveraging towards assessment of behaviors, or correlating them with the future health state, right? So I have this particular annotated wearables data sets available for community. Please contact me if you'll be interested. I just wanted to say that if in your research you realize that tracking, monitoring golfing activities is necessary, there isn't wearable for that, and not even one, but multiple, as you can see on this particular figure. But getting further, if we have all these different technologies, ideal world would be that we have much more continuous and much more frequent continuous, non-judgmental, more sensor-based, and so context-rich data sets, which are then longitudinal and help us to assess the behaviors, the state, the behaviors, the symptoms, the functioning, the aspects which are then important for decision-making in the long term. A side note is that when I set up a quality of life technologies lab, I've looked into different patient-reported outcomes and quality of life instruments, and I got overwhelmed with the aspects of different variables and different measures and different validity. So I have decided to start with World Health Organization quality of life assessment, which is generic, which is translated in many languages, has been developed for many years by many experts, and has been not particularly, it's not specific for a specific patient group, it's really for general population. So looking at the World Health Organization quality of life instrument, we have these domains: physical health, psychological health, social relationships, and environmental. Most likely you recognize this particular larger groups, domains of quality of life. And then World Health Organization calls them facets. So we have different facets between each physical health. So what helps me as a computer scientist is to look at this particular instrument, to look at this particular domains and facets and say, what are important variables to be measured? And then, of course, methodologically going through validity and verification of, do I measure the right thing, and do I measure it accurately, reliably? But first is like, what are these particular facets, variables, which we need to measure? And I'm happy to say that out of 24, since setting up the lab, we have been measuring, quantifying, assessing 13 of those. And I'll be happy to say one day that today we are at 24, but we're not yet. So these are the pros, let's say plus, and of course we're using validated scales, really instruments, for example, pain, for sleep, for others, as you will see in a moment. However, the general big picture is that I think I'm not saying something which is surprising in the sense of building these computational models of different variables, facets, or however we call them, and then looking into how can we, in long term, not only just provide an assessment of current quality of life, but also looking into where does it lead, maybe simulating the current and the future health state and quality of life, and bend the curve. So I want to say that before really getting into the patient-reported outcomes, we've been much more focused on just generally healthy individuals, and also on this, I would call it momentary co-calibration, where we collected the momentary assessment, my assessments of stress, of sleep quality, or moods, physical activity, and other aspects. And we've been looking into how can we quantify the behaviors which people self-report through the technology. And we have a big bunch of research through looking into phone as a sensor. And then let's call it the tech row, right? And the phone is a sensor. The phone is a sensor for being active. The phone is a sensor for being available. The phone is a sensor for stress. The phone is a sensor for different states and behaviors. And the first sensor in the phone, which is then leveraged, is the on and off. Like, how do we switch on and off our phone? And I will not go deeper into this particular results right now, but I wanted to snapshot this momentary co-calibration methods, where we look into, here is a paper on stress, here's another journal paper on sleep, and another one was on the mobile user intimacy perception, when we asked the participants to express their momentary feeling of their, how comfortable they felt in different environments. So really linking to like personal safety and security in different contexts. So here we have different states, behaviors being assessed through just the phone. I have to add here that our secret sauce there is our computer science approach to instrumenting the phone for the data as being a data source. So we not only have an on and off button, and we have actually all the data being recorded and available for us, but we also have the ways of phone being used. So we have interactions, swiping, tapping, zooming, and everything else. And we do also know if you are connected in Wi-Fi versus 4G, if you're mobile, if you're indoor, if you're outdoor, if you're charging your phone, to USB versus to electricity, which proven to be then correlated to different semantics of places where you are. What else? Light sensor has been leveraged in some of the research. We do not leverage any microphone or a video recording, and we have made this decision of not getting into the privacy. But here's the phone as a sensor, our tech row, and here are these particular examples of momentary co-calibration. And again, what I mean as a momentary, because each of these papers and many more, we have been collecting data for 3-4 weeks from the participants' phones, collecting these different interaction cycles, interaction elements, and then co-calibrating, correlating. And actually in these papers, we used machine learning techniques for then understanding, can we predict somebody's stress levels or intimacy levels? Can we predict with, and with which accuracy, the sleep duration? So here it is, the phone as a sensor. Now, today I wanted to talk about further, what's next? Actually, this coQoL approach came from the fact that we have on larger scale available these wearable devices, which are available and they are well designed and they are relatively reliable at this particular moment, and also have many participants who are willing to use them and just particularly forget even that they are in the study. So here's this big picture, which we are striving for. And let me give you an example of a study participants. It's a participant from Hungary, 69-year-old female, and she has a hypertension, self-reported hypertension. And in 2018, when we started this particular project with seniors in the care centers in Hungary and Spain, we have distributed Fitbits. She was already a smartphone user, so that was also very suitable. And then mid-2018, winter, so end 2018, but in 2019 or mid-2019, at 3 different data points, the participants were being called and being contacted for fulfilling some particular self-reports. And here we have example. So what did we have so far? As you can see, the point is that we already have distributed the devices, and the moment when the self-reports of patient-reported outcomes came in, we could already see some particular patterns. So for this particular participant, the nutrition, I'll be very happy to provide the details of the particular scales used. I used some acronym scale. So we had a nutrition, which was nutrition, sleep, PSQI, then social support, MSPSS, then GATS for anxiety and depression, and then EQ5D, and then overall self-reported health levels. The only particular, maybe something interesting as an interesting output would be that she had a slightly interesting anxiety levels at this self-reported anxiety levels at this point, And we had quite a few months of data, so we could see what this particular physical activity, how many steps on average per day this person took, how active per day, and what was sleep, what were sleep patterns. And this here I just give a particular snapshots of this research. However, there is a coming full paper in Journal of Personalized Medicine, hopefully published at the moment when you hear this talk, where you can check all the details. But here I wanted to present this particular ways of looking into early warning systems, right? So then we had the participant coming in and filling the set of instruments, the battery of instruments again around winter, and then here we see some problematic feedback could be given on nutrition, or self-reported health was also not as strong as before. And then what we see that number of steps dropped, activity levels dropped, and also there was more sleep. And then what happened in the next assessment cycle was that here just the sleep came into, actually it was at the edge already of being problematic. It would come as a problematic moment in which maybe some sleep intervention will be required, and none of the other pros has been evaluated as problematic. And again, the sleep, here we are, mid-2019, nice weather, better steps outcome, more active minutes again, and shorter sleep, but maybe sleep is related to the fact that there was some challenges. So this is an example of our participants was purely observational study. None of this particular patient-reported outcomes has been taken consideration for getting back to the participants. She was managing very well, but it's very interesting to illustrate the influence of longitudinal assessments as well as influence of maybe even the seasonal effects, right? And if you would like to get this particular method, the coQoL operationalized, the situation will be as follows. Ideally, we would instrument our patients or study participants with some technology which can capture the behavior markers. And here I give an example of Fitbit once again, because it's on the body and it can capture this particular 24-hour activity cycle, including sleep, physical activity of different levels, sedentarism. But it could be that some aspects would come from the phone, as I said, right? Our previous research shows that the phone is also a quite accurate sensor for other behaviors. But let's stick to the Fitbit or device, a wearable in sense. And then the first step would be to provide it to the participants. And then the second step would be to collect this patient-reported outcomes, to have a self-report, to have validated scales, and to have a variety of outcomes looked into. And this should be coming at the random times. So from our experience, we were not saying to participants when we were going to collect it, and when they were invited to see the scientists, they were not sure what will happen actually. So they were not. This was happening in order to avoid some kind of bias and reactivity in them changing the behavior patterns just before they're going to be tested, right? So then after this step of getting their self-reports, it's very important, the data. What kind of data we're collecting? How do we aggregate the behavior markers data from the wearables? How do we summarize this particular periods? Do we just stick to the recall period of the pro? That's a very important question to ourselves. And then also on the other side, do we look into, depending on the validity of the pro, do we look into individual items, subscores, or overall score, and how do we then interpret it in terms of available data? And again, all the details can be found in the paper, but I will be very happy also to discuss this in the question and answer session. So the next step would be to set up this set of pairs, right, for co-calibrations and derive the Spearman correlations and look for patterns of correlations. And we have set up 0.5 as a sign of looking for signs of a strong correlations already in the data, but as you will see in a moment, we also look particularly, we've been looking at at least 0.5 and then going to 0.8 as really a strong correlation. And then the next step would be, so once we have this co-calibration done on the momentary level, then looking into observing the TECRO, observing the behavior markers, and specifically looking for meaningful changes. And again, we can discuss what's the meaningful change from perspective of technology, right? Like how many steps is really showing on which particular time period that somebody is changing behaviors. But nevertheless, it's looking into changes which will be significant over time, and if necessary or whenever suitable, then call back the person for getting through this self-reports again. So let me show you two, okay, I want to also say it's a developing story from perspective of our patients and participants, because we do not have it yet properly grasped from a methodological perspective, but also it's a developing story for the individuals, right? So they are being assessed, monitoring along the way, and it's a particular aspects of how do we then leverage it for quality of life assessment and interventions, right? Because as you've seen in participant 169, maybe there was a moment we should come back to the person and ask if something changed. So two examples, and then I'll be ready for questions later. Two examples of this result where we had social support through the SPSS scale. We had 39 participants, 18 of them self-reported healthy, 26 females, 70 years old, plus minus 7 of age. And then overall, when they have filled up the MSPSS at least once in this particular waves of participation, they had moderate social support. And then many of them, they had up to 2 years of TECRO data, the Fitbit. And yes, let's have a look at the numbers. Oh, no, maybe not. It's too complex, and we don't have time for this. However, I summarize this. What are these particular strong correlations? So for healthy participants, support of family and specifically friends was at 0.8, was very important. So there was a co-calibration and effects and correlations between these behavior markers by Fitbit, like steps or sleep duration, and then support from friends. And in participants who self-reported some disease, the significant other as a subscore and actually specific items in the scale in this instrument were shown very high Spearman correlation. So how about this? If you have a cohort of participants, we will ask different questions from SPSS scale, but maybe there is a moment we'll pay more attention to specific items or subscores. So for healthy participants, we'll start looking into family and friends, and the moment this correlations gets weaker, we start asking more questions or come back to participants and understand if something has changed in their life, right? There could be some life event. Now, just the last example of this results from this particular cohort. It's the GATS and it's anxiety and depression levels. So overall, we have the same cohort. We have possible and mild. If you just look at the self-reported GATS, the possible mild anxiety and depression, and again, the same cohort, as I said. And again, we have tons of results. However, if we summarize it, we look at the healthy participants. The 0.5 correlation was mostly related to lost interest in things item. And then for disease participants, very strong correlation between their behavior markers and then answer for are you worrying a lot in the scale. So getting through this, I would like to say that one word, 2 words about the fact that having this experience in longitudinal studies with participants, patients collecting data in the wild, in the natural daily environments, there is also a lot of aspects of how to really make it happen and how to assure the data validity collected there. So the human factors are something which we're really incorporating in our research, and they will definitely need to be incorporated in the methods we use. So this is a result of semi-structured interview collected that was at Stanford Medical Center with 200 participants, where we just discussed about how they would use different technologies for health and care, and then I interpolate these results into what would work or not in terms of leveraging the personal technologies like smartphones and wearables, which they will have maybe, or the ones which we give them, into self-care, or would they be happy or not about this? So many participants, no, actually like 20% of participants, 20% of responders pointed out that they would never want to use their personal smartphone for health. And there was some even visibly angry when I asked this particular questions. And then some of them, they really don't want that the phone reminds them about their disease. And then some of them are really disappointed in the technologies they tried. Then there is a mixture of complexity related to technology, but also complexity related to how the data may be used or who is going to use, so the privacy aspects. And there's a group of participants, patients who would say, I would, but I really need to be assured. I'm not really trusting the system. I don't know. And also it's complicated and always asking for password and I don't remember this and that. And also there are some aspects of accuracy. So as one lady said, she compared her Fitbit with husband's Garmin and she dropped Fitbit because she was disappointed it was not providing the same data sources. And then there's a lot of aspects which need to be addressed from human-computer interaction in order to get the engagement of collecting this data passively and longitudinally, and also definitely in terms if you go into the behavior interventions when need to be considered. So not only the interface design, but also performance, the battery, the accuracy, the social sharing aspects, the cost. And I would like to here just emphasize last two things. Is actually when you talk about these technologies, whatever the data we're showing to the individuals, is how do they make them feel? So the emotional aspect is very important, and self-efficacy. So that's one of the behavior theory pillars, self-efficacy, which needs to be emphasized further into taking the person where he or she is and bringing them further in terms of improving their own behaviors and health state and other aspects. So can it work? I would like to say maybe, and we are on the way on developing story of understanding how can we further validate this particular TechRo pro co-calibration method. And we are going to welcome any collaborations, and I'm looking forward to the questions afterwards. Thank you very much.